I think we're saying that NICE would agree with you, but NICE is saying you shouldn't go straight for sertraline. So it's not an appropriate management strategy.
Okay.
Yeah? What was your question?
It was just relating to how you sort of distinguish between, because I put bereavement reaction as well, but I was thinking too about the time.
Yeah.
Is there, because I remember there being something about time, is there an actual cut-off which does seem a bit arbitrary, or is it the presence of depressive symptoms?
It's more than the presence of depressive symptoms, and it's a slightly, it's a tricky one because, you know, a bereavement reaction is not a diagnosis, it's not an illness, and there's always going to be debate as to whether, you know, we're medicalising a normal reaction. There will always be, or there may well be pointers that suggest that it's a kind of, if you like, a pathological grief reaction, or worrying signs would be things like, you know, strong feelings of guilt about the death, or strong evidence of biological depressive symptoms like early morning waking, or, you know, weight loss.
Weight loss at 6 months.
Yeah. So, okay. So what about? We're on to you. What did you have for that one? Which of the following symptoms are not?
I didn't know that one because I would have thought I'm sure you can have increased somnolence. Anxiety obviously is.
Okay. So you thought maybe all of them could be. Or
Yeah.
anyone else have?
I think increased appetite.
You thought. So you thought maybe that wasn't a depressive symptom, yeah? Anyone else? Sorry?
Increased sleep.
Increased sleep, right, okay.
I struggled with that one too.
You struggle with that one. Yeah, it's a trick one. So they can all be symptoms. So, you know, most commonly you will get, you know, insomnia, lack of sleep. But you can get, you know, hypersomnolence, and most commonly you will get, you know, decreased appetite. But sometimes people do, particularly if it's seasonal, it's much more likely to have increased appetite. So trick question there, apologise. How about you? For number 4, these were the options. So that was the lady who thought her kidneys weren't working, fixed belief about kidneys not working. Which one did you go for as a management strategy? I mean, what do you think the depression, the diagnosis would be for her?
Psychotic depression.
Anyone else agree with psychotic depression? So severe depression with psychotic features. And what would you go for if you had to pick one? It's always a slightly artificial situation, isn't it? But what can I ask you what you went for there at the end?
A.
Okay. Anyone else have anything else? So A was citalopram and refer for CBT.
I think of the previous psychosis, probably called C.
Right. So you've gone for searching. Everyone know what aripiprazole is? So aripiprazole is probably the newest of the new antipsychotic medications. Yeah. It's also in the States got a license for depression augmentation and mood stabilising. So
Does it have to be started by a specialist?
you know, it normally would be. Yeah. I think I said that she was being seen by a psychiatrist at this point. So it doesn't. I don't think it has to be. It's not specialist initiated per se, but I think she'd be needing a community mental health team input, I'm guessing. So anyone else go for anything other than A and C? So C being, sertraline and aripiprazole. No? So I thought C for the reason you said, because she's developing some psychotic ideation to do with her kidneys. It's quite common to have delusions about bits of your body not functioning, preoccupation. Often people get, preoccupied with their bowels not working, there's a blockage, and as you said, given that she's got this previous history of a psychosis, you want to sort of try and treat that as early as possible. And the other thing is, if she's, people, citalopram and CBT is not unreasonable, but often when people get very preoccupied and ruminating, it's hard to kind of get that sort of ability to step back from their thoughts that CBT really requires. So I think that's why I think C. And the evidence is that if someone's got a psychotic depression, you do need to treat both. Just treating the depression isn't really going to be enough. Is that what you would say?
Yeah.
Yeah. Okay.
On what's interpersonal therapy?
So yeah, interpersonal therapy is a therapy which focuses on any sort of interpersonal difficulties that could be maintaining the sort of depressive picture. So it's in the NICE guidelines for depression, but kind of is in the shadow of CBT a bit. You'd use it if there were clear, I suppose, interpersonal difficulties. It's not widely available as
So
well.
what does interpersonal mean then?
Oh, sorry. So you know, relationship difficulties,
Okay,
but that are clearly maintaining the depressive picture.
Any particular reason they're in focus, or?
I just chose it as a kind of newer antipsychotic. No particular reason. But it's one of the more sort of potent ones.
I always wondered what happens to very old people. Do they do well on any psychotherapy at all? Because one has to have a certain mindset.
Yeah.
For psychotherapy.
I think the answer to that is my experience is that, you know, some younger people will get and benefit from CBT, others won't get what's required. And the same really is true of older people. You can't make assumptions based on their age really. So I think I would always, and have done today, in fact, asked our psychologist to see someone for suitability for CBT, someone who's on the board. So I've seen it help a lot of people, you know, of older folks. So, okay, we're on to you. So what did you have for that one? Which is, that's a really techie one, isn't it? Technical.
So I know you can use lithium.
Yes, you're right.
I think
Yeah.
you can use valproate as well.
Anyone? So what
found
did
it
you go
hard.
for?
Well, I was torn a bit between A and E actually. I'm not sure about quetiapine for it. I think I have seen that one used.
Yeah. Okay. Anyone else got any?
Or venlafaxine CBT, that would have already been tried. That would have thought for treatment resistant.
Yeah, it might have been, although they might be sort of focused just on medication, so different medication gone, ooh, wonder if she benefited from CBT.
So, A.
Anyone else got any offers?
Accepted.
So SSRI and mirtazapine is actually a very common combination. Venlafaxine and mirtazapine is particularly common. We're talking about, this is secondary mental health stuff, I would say. Actually, NICE specifically say that there isn't enough evidence to say valproate for bipolar disorder, and it's, but not particularly good for bipolar depression, which I haven't really covered today. But yeah, that's NICE are pretty clear. There isn't enough evidence for valproate, and valproate can be pretty nasty stuff, can't it? So the others, lithium, you knew that gets used. So it's not just for bipolar. It's good for antidepressant augmentation, and seems to have a specific kind of anti-suicide effect. Suicide rates are lower for people who take lithium compared to other people who have depression. Quetiapine is in there because it's actually a licensed indication. Quetiapine has a license for augmentation, and in the States, I think all the atypical antipsychotics have a license for it. And venlafaxine and CBT, again, it's that idea of combining a biological treatment with...
Is there evidence then for combining antidepressants?
It's a good question. I'm not aware that there are RCTs. It's more kind of... exactly. And NICE, I think they've specifically... It's included, you're right, it's included in the guidelines, but as a kind of, it's widely practiced, and venlafaxine and mirtazapine is probably an even more common combination. Okay.
Can I ask a question about that previous one?
Yeah, go on.
Because you said there's sort of, maybe secondary mental health questions, maybe,
Go on.
but would it be reasonable for GPs to try adding in mirtazapine?
I think so. It's pretty...
I'm always worried that I might give people dreadful side effects, or...
No, I mean, mirtazapine is, that combination is, it's pretty safe. I think if you're combining something like sertraline and mirtazapine or escitalopram, which don't have this sort of QT prolongation effect particularly. And what was that? Well, yeah, and that's what you would have to look out for, is the sort of risk of serotonin syndrome. Again, not very common. And that might, but you'd warn them if they're more agitated, if they started kind of sweating or feeling tremulous, then, come
So
back.
if you're going to do it, sertraline, escitalopram.
Yeah, and I think of those combinations, I think that's the safest one to try in primary care. Yeah. what did you have for this one? So this was the man who, again, has developed a pretty nasty sort of, for him, belief about his wife. He's pretty depressed and he's not eating and drinking very well.
I went for ECT.
And you will not go for ECT there? Any other suggestions? No. Yeah. Good.
What's the fine thing? What does she
It's a
use that?
it's an old-fashioned
It's a
tricyclic. And in fact, I put that there because NICE specifically say don't use it in older people. It's too kind of cardiotoxic and anticholinergic side effects and so on. So
So you go straight for ECT there.
because he's basically going to die, and then because he's dehydrated, the other things wouldn't have a quick enough onset of action. Basically, bereavement counselling I kind of put there as a kind of slightly black humour, in the sense that his wife's, he's deluded about his wife, so that wouldn't be very, very helpful for him. The sertraline, that might help him, but he's at this critical state really, and the advantage of ECT is that it does work quicker. People can benefit from it within a couple of sessions, a couple of treatments often. So that's a week, whereas a lot of this stuff in the community you'd be thinking, 6 to 8 weeks. Well, we might give it a couple of weeks longer, and he's not going to survive that long. So
is ECT quite safe in older people?
I mean, it's still,
I know it has to be sort of at a point where you're desperate.
absolutely, but yeah, it is.
Generally.
It is safe. We in a meeting recently, we haven't had any. The main risk is the risk of the anaesthetic, basically, and it's about the same risk as having a dental procedure. And we've not noticed any. We've not had any sort of sudden deaths or anything. Oh right, 3 minutes. Okay. Okay. And we're on to you. That was the 8-year-old woman who's got some sort of maybe fairly mild symptoms, but she's got that past history of being very unwell. And if you had to plump for one of those, then what did you think?
That was what was making me waver a bit.
Talk us through the wavering. What was your thinking?
I thought she looks like mild, relatively short history, reasonably mild symptoms. So I was sort of thinking then, CBT or relate, thinking about how she can start working on problems. But she has got this history of being vicious.
Yeah.
So I plumped with C because it felt like something a little bit more
Okay.
that relate.
Yeah.
But yeah.
Anyone have anything else?
D.
You went for sertraline. And was that along the lines of her
Well,
thinking
I
about...
was between C and D, so I agree relatively mild, you can probably get through it with CBT. It's just that, again, the access difficulties of CBT, and the fact she responded well to it before we wanted to have it. If it worked then, she was happy with it.
Anyone else?
I went for A or B, to be honest.
Yeah, okay. A or B?
Because if you're following her up, then
Yeah.
you can change your mind.
Yeah.
D, but for a different reason.
Go on, what was your reason for D then?
Because she had responded in the past to SSRI, so I thought might.
Yeah. Well, that's what you were saying, really, wasn't it? You were all saying that, but you sort of decided. Yeah, I mean, I actually went for D. I think your choices are all reasonable, actually. What you were saying, you're following them up. You're offering an